the first presentation of, well, first webinar really, of 2013. So for those of you who are new here, we do this every month, and we post online as well. So if you do miss anything, it's going to be online in the next couple of days. At the same time as well, we'll post these mind maps up as well. So you can have these as well as aid memoirs in a sense in your consultation room. Today, the topic, we're going to be looking at four specific areas. I'm going to have to manage the time very carefully in order to make sure that we don't run over. I'm going to try and aim to finish off by very latest at 9 o'clock. And we've got four areas that we're going to look at. Next month we're going to be looking at a few other clinical areas as well. But this month what we'll be doing is we'll be looking at four specific areas. That's asthma, COPD, diabetes, and depression. Diabetes, we're going to be looking mainly, and actually we're going to be looking specifically at insulin-dependent diabetes. Now that could incorporate type 1 and insulin-dependent type 2 diabetics as well. Much of the sort of advice you was given in MUR is actually quite similar, as also is the sorts of advice that you would tend to give for asthma and COPD patients as well. Those of you who are a bit unfamiliar with the way which I tend to do this, or there's information that we're going to need to get through in the next couple of next hour or so. And to do it in a presentation format with PowerPoint and all this sort of thing, it gets very, very difficult and also quite monotonous as well. So there is a technique called mind maps, which is what you see in front of you, which is what we use to try and sort of like be slightly more different than just simply a rolling PowerPoint presentation. I've muted everybody. However, if you've got a radical question that you want to ask, then feel free to put. Oh, sorry, I've got my mic keeps on fading out. Can you hear me? I'm going to try talking on. So if anybody can't hear me again, please do let me know. Sorry, I've lost my point. Okay, so people can hear me now. That's great. Thank you for that. I'm gonna make a start now. So we're going to go through four areas. We'll start on depression and we'll end up on COPD, I think. And what we'll do is, so we'll get questions. So you've got, I think people here are using the chat function quite well now. So if you do have any questions in the meantime, feel free to post them online. And what I'll do is I'll go over one by one as we go along. So let's make a swift start. Now what I'm going to do is the depression element. The few things here that I think we as pharmacists, oh crikey, sorry about this, my computer's crashed them again. This is very good. I do apologise for this. I don't know why it's doing this. It's not letting in. Okay, bear with me a minute. I'm just going to try and figure out what on earth is going on here. Just bear with me. It's not me. Oh, crikey. Alright. I do apologize for this. It's doing something funny again. So I'm going to end this task. I'm going to try reloading it again. So I'm going to just reload it. Hopefully we'll get something better now. Okay, I think we're coming up now. Sorry, I don't normally get these sorts of issues with the computer. For some reason, I think it's on some sort of drinking binge or something, and that's okay, right. I'm going to close off a few of these, so at least that way it will save on some space. Okay, let's start off with depression and MUR type 2. Okay, we're there now, I think. Okay, good. And hopefully it shouldn't crash on us again. Now, with depression, what we're going to be talking about is 3 specific therapy areas. I've purposely not gone into things like benzodiazepines and some of the anxiolytics. I'm looking specifically at 3 different classes of drugs: the SSRIs, the tricyclic antidepressants, and lithium specifically. Now, with SSRIs, I think you're probably all aware of the fact that they're first line, and examples which are sertraline. There are other sorts of things like fluoxetine and variants of that as well. Citalopram is quite a common one as well, although it's not technically an SSRI, but it's similar to that. And the first thing that you need to be aware of with an SSRI is the need to monitor and possibly refer patients who are using it who are under 30 for the following reasons. So, for example, if a patient in MUR displays things like akathisia, which is basically a condition known as restless leg syndrome, quite a lot of anxiety, because in actual fact in some people it can have the opposite effect, agitation and suicidal ideation. These are all elements that you need to be very, very careful about and refer to the GP if necessary as well. Especially suicidal ideation, there was an MHR alert, I think, a while back for this particular issue in adolescents. So if any of the patients display any of these, then again refer them. So I'm going into this a bit more detail a bit later. With the tricyclic antidepressants, a common thing that you may experience is the increased risk of falls. Partly because of the fact they can make you drowsy, but also because of the fact that it could cause postural hypertension, which is when you stand up quite suddenly, when you start going very giddy, that could cause a risk of falls. And bear in mind the fact that TCAs tend to be prescribed in elderly quite a bit as well. So that's one other area which you may want to be aware of. And I mean, I probably don't need to go into it in too much detail, but the sorts of things that you would want to be aware of is making sure that the patients have got warning cards, that the interactions with non-steroidals, and especially with drugs that have got high sodium content. So bear in mind things like soluble paracetamol or whatever. That could actually have an effect on lithium. Also making sure that the patient is being monitored and they've also got adequate hydration, so they're drinking enough. So these are all basic things that these antidepressants, the MUR sorts of tips that you may want to raise in a specific MUR specifically for depression. There are other things that I'm going to quickly go over as well. Now, believe it or not, about 7% of patients are in some way or another non-concordant to antidepressants. So there is a huge potential to educate patients in your MUR with regards to how to take these sorts of medicines. And the sorts of advice that you may want to give, and bear in mind the fact this is all going to be posted online, so don't if you're taking notes, don't worry too much about it. You'll get all this online. It can take anything, especially for the SSRIs, anything up to 4 to 6 weeks to work. So really, you need to persevere with it. Second thing is that even after the resolution of symptoms, ideally you would want to take it for at least half a year thereafter as well. The reason is that the relapse rate can be anything up to 50%. So sometimes what could happen, you could get a patient saying, you know what, I feel a lot better, I'm weaning myself off the dose. Probably not a good idea without talking to the GP about it. So if you do see something like that happening, bear in mind the fact that patients who tend to do that can relapse quite there's a significant amount of relapse there as well. It might be to mention to the patient that these drugs are not addictive. There are other things as well. So for example, one thing that could happen if you forget the dose, don't double up. Explain side effects. Now, the thing with treatments is that it's not a sudden stop. You need to reduce these drugs carefully over a period of at least a month or two. And sometimes there can be something called a discontinuation reaction. Now, that could mean slight amounts of agitation, etc. But normally, they last for about 5 days and will be short-lived. These are the sorts of things that from experience, when I've done MURs, and not just MURs in pharmacies, but also when I've worked in sort of level 3 type medication reviews in GP practices, these are sorts of things that tend to come out in a consultation. So, it's basically initiating treatment, maintaining treatment, and also stopping treatment tend to be the big issues that seem to crop up. So, from experience, these are sorts of things that may be a good idea to talk to somebody who want to give a bit of advice to on antidepressants. So that's the accordance issue sorted out. Now, let's look at this from here. To refer now, we've already spoken at length with regards to the issues, especially with the lithium and some of the other areas which we talked about. Now, when to refer now, if say for example there has been absolutely no improvement in the patient's condition after around about a month or so, it might be an idea to suggest to the patient to refer them back to the GP. Bear in mind the fact that sometimes it can take anything up to 6 to 8 weeks for a response to take effect. But if there's been absolutely no change whatsoever, then it may be an idea after about a month just to get the GP to have a quick look at it to make sure that there is no other reason why that's not happening, and perhaps maybe even to change medication as well. There are a number of different side effects that can occur, and that possibly, I suppose, we could actually have given in the additional advice section. You may want to consider changing the antidepressant if some of these symptoms are intolerable. There is a possibility of something called hyponatremia, which is a low sodium content, which could lead to things like dizziness, confusion, cramps, and requires monitoring, especially in the elderly. This is quite common, for example, in the tricyclics. Again, blurred vision. That happens again if the patient complains about that. It'd be a good idea to see the GP optician. It's actually related again to the tricyclics too. The issue with the tricyclics particularly is urinary retention. So especially, for example, if it takes more than 5 minutes or so to go, then again you would want to see the GP again about it. Again, you've got the issues related to things like the sexual dysfunction, which is an issue with depression itself, but also with some of the drugs as well. So all sorts of side effects you could manage in an MUR. You could try and pick these out if it comes out. Let's just reduce that again now. There are various interactions that can and do happen. Example is St. John's wort. So you may, for example, get a patient coming in when you are saying, I'm on St. John's wort, or it might actually be buying it as an OTC. So just be careful when a patient actually asks for that and is on an antidepressant. The SRIs and non-steroidals, especially in the over 80s, can be an issue as well. So just bear that in mind too. The chances are that there's nothing much you can really do about it, but just bear that in mind. And in warfarin, the most common recommendation to start off with is citalopram. So just bear in mind if the patient is already starting off warfarin. Again, the most common ones which seems to have come out. And I know I'm going very fast in this, so I've got quite a lot to get through, especially with the issue that happened earlier on. These are the side effects. So the practical tips, for example, as to what you can do to help patients who are experiencing some side effects. So, for example, you might get nausea and sleep disturbance, especially with SSRIs. So, if it does happen, it may be an idea to take that in the morning instead, so the sleep disturbances tend not to happen. Now, with tricyclics, drowsiness is a potential issue. And this is the case, it may be better to take that at night time. There is one called lefepramine, which tends to have a slightly reduced incidence of drowsiness, so that could be a potential area there. That if the patient is complaining about excessive drowsiness, a recommendation of a switch may be appropriate there as well. One of the issues with tricyclics is a dry mouth, and in which case you could suggest boiled sweets or sugar-free gum, drinking on a regular basis as well. But unfortunately, that is one of the side effects of tricyclics. There's nothing much you can do about that. Constipation, again, an issue with the tricyclics. Usual sort of advice would be to increase the fiber intake and water content in your diet. And finally, when initiating somebody SSRIs, there is a potential that you could get diarrhea to begin with, and that is quite disconcerting for many patients. So a good advice here would be that it is a self-limiting issue, so don't worry too much about it. It tends to go away by itself over a few days. However, the stomach issues do carry on. It may require a change of therapy altogether. So practical tips there, especially if you're in MUR and the patient's worried about certain drugs for depression. Now, I think I've gone through all of this. I've done through that one. Bear with me, I've lost track now. Here we are. Okay. Now, there's some additional advice that I suppose you could also give. Now, for example, especially with antidepressants and the TCAs, the tricyclic antidepressants, your action time is reduced even if you're not tired. There's a possibility, for example, of accidents and those sort of things occurring, especially when patients are starting off with TCAs. It doesn't say that they can't drive, but it's just something for them to be aware of. I did mention something about benzodiazepines earlier on. I haven't really focused upon it that much this time round, but again, obviously, if the drowsy effects do take over with benzodiazepines, you don't want to be driving with that. But here, I'm concentrating mainly upon the tricyclics here. With stroke, one of the issues here, especially if you're doing an MUR on a patient, is that, as you probably imagine, depression occurs a lot of the time in patients who have had stroke. I mean, I think when I read about this, I think the statistics were about 30% or so. It's a third of patients get some sort of observable depression after this. And at the end of the day, it's their life is sort of like changed dramatically. They become dependent upon somebody else, possibly less independent on them, so less dependent upon themselves. And if that's the case, if you do notice a patient who's feeling, pretty rotten about themselves, especially if they've had a stroke, they can actually be prescribed antidepressants. The most common ones used are nortriptyline or SSRIs. Advice: remember we mentioned that it takes up to 4 to 6 weeks for it to work. Special note about, again, I'm focusing on this again, the suicidal ideation. So if anybody, especially if they're under 30, as you mentioned, anything about like this, is an immediate referral back to the GP. Bear in mind the fact that it can take up to 6 months or so for the symptoms to resolve themselves, and in the elderly it can take even longer. So these sorts of things here are sorts of advice that you can give in a practical way to your patients if they are experiencing issues with depression. I'm going to just stop for a few seconds to see if there's anybody who wants to ask any questions in the meantime. So I'll hang on for a couple of minutes. So if anybody wants, then please feel free to write it in the chat box. Anybody wants to talk to me? Okay, fine. So this is the depression side of things. So I'm going to this map now. If you have any questions, again, just feel free to type them in. There's no problem there. I'm happy to answer that. What we'll do now is we'll go over the where is it? The diabetes one. I think that's the one. That's the one. There we go. I focused here specifically on patients who are using insulin. Now, I've done quite a lengthy webinar previously with regards to some of the newer diabetic agents that are around. So if you want any more details on some of the newer agents that are around, then go onto the website. You'll be able to download one of the webinars that we've done previously. But this time around, what I've done is I've focused specifically on insulin because I've tried to incorporate type 1 and independent type 2 diabetics as well. So if you do have a patient who has diabetes and you're looking for MUR tips, the sorts of people you may want to look at are the ones here. So those patients who have been referred directly from another healthcare professional, those who have got changing insulin equipment and other requirements as well. This is an interesting one here as well. Those who return on a regular basis unused medication. Now, I mean, I'm not going to teach you to suck eggs, but that probably indicates that patient isn't using their medication as directed by the GP, or the GP thinks they're using it, but they're not. So the other thing that could be an issue as well that you could resolve in the MUR is when a patient has problems ordering medication as well, especially from the GP. So these patients are the ones you tend to look at more specifically. Now, let's look at the sort of general advice that you would give, especially in the MUR. Okay, I'm going to open this up. Oh, there we are. That's good. Now, first thing is confirm the insulin types that the patient's using. There's a whole variety of different insulins there, and one of the webinars I'll be doing in the future is to sort of like go over different types of insulins that are out there and basically the way in which they work and so forth. So, but it's important that the patient, you confirm the insulin types of the patient. It's very easy to give out the wrong one, or it's very easy to confuse the two as well. Also, confirm the injecting devices as well. You've got a whole variety of different types. You've got auto pens, you've got the cartridges, you've got loads of different things out there. You've even got the vial still as well, which are steadily being phased out. Again, just to make sure that the patient is being given what they should be given. Single-use devices. So, for example, when a patient is being given a single-use device, make sure that they have actually been given it for single use. Anyway, you've also got sharps disposal, so that the patient know how to get rid of the sharps appropriately, where to return them, etc. And they got the appropriate means to dispose of it as well. Now, self-testing. This is a little bit of a difficult one, especially for the sort of cost cutting that's going on nowadays as well. It may be an idea for you to look at local guidelines. So if, for example, you've got a good relationship with a GP or your PCT, then maybe an idea to give them a quick shout and ask them what their guidelines are for self-testing. Now, with 1 diabetes, you would test on a regular basis. Again, especially also with type 2 diabetes, if you're insulin dependent as well, you'll be testing on a regular basis as well. The problem actually arises whereby people who are type 2 are using extraordinarily large numbers of insulin strips when they're not using insulin. So, for example, if they're on metformin or something like that, whereby you don't tend to need to use strips on a regular basis. So, just look into the self-testing and making sure that their ability or not the ability, but their understanding of the technique and the meaning of the results is appropriate as well. So, do they understand what if they get a blood sugar level of 10 as opposed to 4, for example? One common thing that has actually cropped up when I've done MURs and other reviews as well is thrush. And especially in patients with diabetes, that may indicate poor control. So if a patient is displaying those sorts of symptoms on a regular basis, it may be an indication to either check their blood glucose or the HbA1c levels and make a referral, if appropriate, to the GP. The other thing is just to check when the last time they saw the diabetic nurse at the practice as well. Normally patients would tend to see them if they're relatively stable every 12 months, but What sometimes happens is that GP practices forget, or the patient forgets, and sometimes they don't get seen for a while. But you know, an appointment with a diabetic nurse every 12 months, it needs to be done. Now, this is where we start going a little bit more clinical now as well. So you get a report. You might get additional information, for example, in the MUR. I mean, technically an MUR is not a clinical review, and it shouldn't be reviewed as such, but you may get this sort of information, and you might be wondering what to do with it. Now, HbA1c is quite an important measure of the historical blood glucose, of the glucose concentration in the hemoglobin. And it's a good indicator as to how bad or how good your diabetes actually is. Not what you do with insulin-dependent ones. You tend to measure them every 2 to 6 months. You would expect to aim for a range of between 6.5 and 7.5. There is glucose as well. I haven't put that in. I don't know why I haven't, but there isn't. I haven't put that in. Again, that's something that you may want to check in the pharmacy as well. They have blood pressure checked as well. So, for example, they would want a blood pressure of less than around about 130/80. I mean, there's other nice guidance, especially for patients with diabetes and hypertension that has come out. So, but you would aim for that sort of blood pressure. Again, you would aim for a concentration of less than 5 mL. To make sure that they do, especially with type 1 diabetics, that is a urine protein test. That actually gives an indication of the kidney function. Now, this should be done annually, and if they've done it annually, you need to get it done. And if it is working out very well, if there is detectable amounts of protein in the urine, you may want to consider recommending, well, you wouldn't, but the GP would probably then consider recommending an ACE inhibitor to actually help with the kidney function. That could be grounds for another MUR in the future as well. Other things that you could raise: has the patient had an eye test recently? Have they had their feet checked as well? Bearing in mind that you get retinopathy, and also you get poor levels of foot care with patients with diabetes, and more prone to infections or more serious infections. And finally, you could query them about the general health, so obviously thrush and erectile dysfunction, and in this case they may even be suitable for erectile dysfunction drugs on the NHS. So a lot of things there you could potentially discuss with patients with diabetes. Now, I've gone over this bit. Yes, I've gone over this bit now. With life advice, there are all sorts of things that you may want to discuss. Then you are the diet, the weight management, exercise, smoking, sin, alcohol advice. I mean, you can name, I'm sure, a few other things as well, which could go on top of that. And bear in mind that a lot of these other things could then refer on to other services. For example, God forbid, if a type 1 diabetic is still smoking, that could be grounds to obviously put them into a smoking cessation scheme if you've already got one. That, in a nutshell, is some advice that you could probably pick up in MUR for patients with diabetes. So I'm going to close this one out. Oh, by the way, has anybody got any questions that they want to ask on this one before I move on to the penultimate one? Thank you, Hitesh. That's very nice of you. Okay, bearing in mind, again, you're going to get copies of this online. So if I'm going a bit too fast, you will be able to look at this in your time. The whole idea behind this, by the way, is I want to create a whole sheet, maybe about 13 or 14 summaries for you to keep in your consultation room. You can refer to these when you're doing these consultations as well. This is specifically diabetes. Now, what I'm going to do is I'm going to close this map, and hopefully everything's not going to crash on me. Good, it hasn't yet. We're going to go on asthma. Now, sorry, this looks pretty awful, but it isn't really. Okay. The last two are going to be very similar to each other, asthma and COPD. So a lot of the tips that I will be giving on asthma can also be applied for COPD as well. So COPD mind map that I've created is not going to be as big as some of the others that you will see, because a lot of the things that you'll see on the asthma can be equally as applicable. Anyway, what I'm going to do is I'm going to do the usual sort of thing and just click on each one of these and describe to you the sorts of patients you may want to look out for. So, asthma. You may want to look at patients who are overusing their inhalers. So, for example, are they? For example, with salbutamol. I mean, how many times have we seen a prescription for 2 plus 4 times a day? Generally, that's not recommended. If they're using that sort of level of puffs on a salbutamol inhaler, they should really be on a steroid-based inhaler. So just bear that in mind. So if they're overusing it, if you're noticing that they're over-ordering it, then it could be grounds to bring them in for an MUR or prescription intervention service and then talk to them about it. And then that I've seen in the past as well is patients declining specific items. So for example, it might be on their prescription, but due to cost reasons or whatever, patients saying, I don't need that brown inhaler. Well, why don't you need it? It's been prescribed for you. Is there anything that's going on that I should be aware of? It could be something as innocent as saying, look, I've got another inhaler at home which I haven't got. Or it could be something a little more sinister in the sense that that they don't quite they're confused about the fact that it's a steroid inhaler and it might harm them. So if they are declining a particular inhaler, it may be an idea for you to have a quick chat with them. Again, another grounds for an MUR there. Now, I'm not proposing that you go through the whole of the inhaler technique with the patient's MUR, but if you're orientated that way, you could do that. You could test their technique in the MUR just to make sure that they know how to use it. I do recall a very funny story a long time ago, when it was before the era of MURs, but I do remember when a colleague of mine asked the patient to come around the back and check his technique. And what the patient did was spray it up into the air and sniff it. So obviously that patient hasn't been taught how to use the inhaler. And there was other quite, I don't know if it's an urban legend or not, but there was one story that I heard whereby the patient actually used to spray the cat, thinking that that actually reduced his allergy to the cat. All these things, I mean, it sounds daft, but all these things could potentially be, you might find funny stories there as well, but all these things could actually come out in the inhaler technique argument. Bearing in mind the fact that each one of these could be just as equally as applicable to a COPD patient. Now, changing formulations, there has been a lot of change in terms of the types of inhalers that are around. So, for example, you might have the e-inhaler, you might have the AccuHaler that's around, you might have an auto-inhaler, all these different types of inhalers, different ways of inhaling. Again, you can check the patient summary. The problem with this, however, is that I am aware of the fact that pharmaceutical companies are a bit more reluctant now to give placebo inhalers. I'm not sure why. I think it's probably for cost reasons, but I mean, if you do need inhalers, you can let me know, and I'll see whether or not I can use some of my resources and my contacts to get some for you. This is something that might be something that you want. Just type in the chat box, and I'll see what I can do for you. Emergency supplies, the patients using a large number of emergency supplies probably indicates the fact they're not seeing their GP. Again, possible grounds to do an MUR with them. And last one is unopened inhalers. So a person brings back a bag full of expired inhalers or something like that, again, would probably indicate that they're not using it very well, and you would probably want to bring them in for an MUR. So again, all these things equally is applicable to MUR, so to COPD patients, and the sorts of patients that that you can use. Okay, then. So some tips. Now, this is quite a big one. let me zoom out a little bit and not let my computer crash on me. Oops, that's better. Let's do it to 100. Let's just do this, leave it like that. Okay. Now, the sort of things that you may want to talk to the patient about and discuss with the patient. Understanding the inhalers. Do they know what the inhalers are about? Do they know what the blue one's about? Do they know what the brown one's about? Or do they know what the purple one's about? Or whichever colour happens to be? So do they know when it's meant to be used and what they're meant to do? So for example, obviously there's a difference between salbutamol and the steroid-based inhalers. Do they know when to use it and how they use it? Compliance, for example. Is they using matching how many times you actually is what they're using matching what you're giving on the PMR as well. Again, you can check back. So if they're using a large number of if they're getting a large number of prescriptions which doesn't match your on PMR, again something that you might want to talk about. You can check technique and also their understanding when the inhaler is almost empty. Even I have difficulty in figuring out when the inhaler is actually going to be empty. And a number of times when the patients come to me and say, look, my inhaler is empty, what do I do? So you need to actually counsel the patient how to do that. Again, I'm not going to go into this too much detail. Synchronization with expected date of the new prescription. So for example, is the prescription coming in too quickly or is it coming in too late? And if it is, why is it? Are the instructions on the inhaler readable? To discuss these side effects. So, for example, has a patient got oral thrush or so forth. Now, over-the-counter medicines to alert the patient to the fact that there could be sensitivities to aspirin or ibuprofen. I suppose one thing I did miss out here was cough medicines as well. So you may want to raise your awareness of patients on that. Are they using a spacer, and if so, how are they using it? Are they using a peak flow meter? So in other words, how to monitor when a patient's asthma may be getting worse. So for example, with this particular instance, you would want to tell the patient that there should be consistent readings throughout the day, that a marked decrease in the peak flow could indicate worsening asthma, and have a diary which they're using as well. Again, it could mean a potential prescription for you again if they are not using this, and I would probably bet quite a few patients are not monitoring their peak flow on a regular basis, and if you're able to identify this, you could potentially get another prescription as well. The issues also with generic prescribing. Remember the beclomethasone inhaler, the Q-bar and the Clenil, two different inhalers at the same dose. They are not bioequivalent. So those sort of things can be quite confusing to the patient. And another thing is the smoking status of the patient as well. They are not. They should not be smoking. If they are, again, you can refer them into the smoking cessation service. All of these things you potentially could talk to the patient about, and some of these could actually mean additional prescriptions to you if need be as well. Now, I'll go into the drug issues as well. Now, there are a variety of different drugs out there. Again, if you want more information on asthma, we have done another webinar on that. You can go online and read detail about the effects of corticosteroids, for example, on high-dose corticosteroids on patients. But here we're going to keep very short and sweet. So I'm going to be going over let's relievers first, because that's the first thing that you would tend to use. The sort of thing you want to tell the patient: it works quickly, you'll get a 3 to 5 hour duration, use it when you need it, and it's a bronchodilator. In other words, it expands your airways. Very simple. Corticosteroids, this is where you might get a little bit more confusion. It's different from a reliever because you use it on a regular basis as opposed to an ad hoc basis, is what the reliever does. It's an inflammation, but you need to let the patient know it can take anything up to a week to work. 3 to 7 days normally, so they do need to use it regularly. Keep in mind the fact that you can get oral candidiasis, So you can check that technique and tell them to wash their mouth as well. And also high dose corticosteroids. We've got a whole separate webinar on this if you want to learn about it. You would want to make sure that the patient's given a steroid card, and also for other nasties that could happen, adrenal suppression and other sort of bone growth issues that can potentially happen at high doses as well. You probably wouldn't want to mention that to the patient altogether, but especially you would need to want to give them a steroid card at least. So all these sorts of things here you could mention to the corticosteroids, so especially, for example, the regular use to reduce inflammation and the time it takes for it to work, and perhaps even the candidiasis as well. Now, thirdly, there are bioequivalence issues as well. Make sure, if possible, that they are given and prescribed the same brand of theophylline each time. Now, betas. Now, I'm actually my daughter's slightly asthmatic, and she's about 6 years old, and we still have a spacer for her from when she was 3 years old. Really, I should have thrown that away, and being a pharmacist, she could probably tell that I should have known about this. But bear in mind that, spacers do deteriorate over a period of time. They do need to be cleaned as well. You don't want particles of corticosteroids and beta agonists, whatever, are around there as well. So wash it out with, tell the patient to wash it out with Fairy liquid or Tesco liquid, whatever liquid you want to use, at least once a month. And also replace it every half year to 12 months as well. So this could potentially mean another prescription for you as well. And also good patient care too. Other style advice you may want to mention, the smoking cessation is a very good one. You could actually refer the patient into a completely new service and also get funds for it accordingly as well. Patients with asthma should not be smoking, and actually nobody should be smoking, but especially patients with asthma. And sorts of things, avoiding the asthma triggers. For example, is it activated when they're in a smoky room, or is it activated when they go into a cold room, or whatever? Just to mention that to the patient as well. And finally, the other sorts of things that you may want to mention to the patient, if you're interested, again, we have another webinar on this. If you're interested in sort of like developing your knowledge in asthma, we have got a webinar on discussing the steps related to the progression of asthma. And if you're really interested, you can download that at the British Thoracic Society website as well. It's generally a 5-step process, but a very good one as well. It's very clear and concise. But again, if you want a copy of it, you can always email me and I'll send it to you, or you can check out one of our webinars in the past specifically on asthma. Again, you would want to refer the patient if they've had no review in the past 15 months, and also if the symptoms are poorly controlled as well. So if the patient's overusing their inhalers, as I mentioned earlier, if they're underusing it and the peak flow is completely up the creek, then again that is a referral. So all these things again, hopefully it sort of triggered your memory. It triggered your memory on these ones, especially with the if I can find the hints and tips here. I found that that's actually going to be quite a useful thing from experience to use in an asthma type review situation. Okay, so that is for asthma. I've got a comment here from Hitesh as well, who's made a very good point. The tone test inhaler is meant to be a good resource as well. So Hitesh, for that, I do appreciate your comment there. So just pass that around to everybody too as well. Now I'm running quite short on time because the issues we had a bit earlier. So I've got 10 minutes to finish this one off. As mentioned earlier, a lot of the stuff that you'll find on COPD is going to be related to inhaler technique and those things. And you can pull it up. Here we are. If you compare this particular mind map to the asthma one, you'll see that it's the same sort of people you'll be looking at. Those who are being referred from another healthcare professional, those who are overusing their inhalers, those who are declining the use of preventers, inhaler technique, including spacers if necessary, changing inhaler types, and opened inhalers. So the sorts of patients that you'll be looking at for COPD will be very similar to the patients that you'll be using for asthma as well. So hence the reason why this particular map is actually a lot smaller than the others. Now, however, the sort of interactions you'll get are going to be slightly more different. Obviously, COPD is a completely different clinical condition altogether. It's managed in a different way. Sorts of advice you would give is going to be very similar. For example, with the short-acting bronchodilator, again, it's a PRN dose. Examples here would include salbutamol, sabutaline, or anticholinergics, ipratropium, for example, or tiotropium. They tend to be used around about 3 to 4 times a day. This does actually trigger a memory of mine. If any of you are interested, there's a very good podcast that I think it was an American poem. There's an American poem, I think, patient-orientated evidence matters that came out, I think, about 3 months ago, that tried to determine whether or not anticholinergics could be used in asthma. And they found that very few patients with asthma actually corresponded or actually responded to anticholinergics, which is rather unusual. Well, which is I was expecting something completely different. But that's actually that's completely separate. It's completely different. But it's something that you may want to. If you want the link for that, I'm happy to send it on to you. But a very good podcast that you may want to listen to. Sorry, I'm diverting from the point here. Patients who are on beta agonists and short-acting anticholinergics such as Combivent, etc. And again, you use that 3 to 4 times a day. A long-acting bronchodilator. Now, there are four different types of these. You've got ephemetrol, salmeterol, and tiotropium. You tend not to use these in asthma. It's more sort of like COPD orientated. They tend to last for over 8 hours as well. So these are sorts of drugs there that you could use. Now, for moderate to severe COPD, you tend to use a combination of these long-acting bronchodilators with inhaled corticosteroids. So that's the reason why you get these bizarrely high-dose serotype inhalers, 500 for example. It's a dose of corticosteroid to take, but that sort of thing is licensed for COPD in that term. So hence, for example, if somebody using high-dose corticosteroids, you are probably going to want to give them things like the steroid cards and the issues associated with that as well. Exacerbations, I suppose this could also be put in the asthma MUR, and I probably will do that as well. Oral steroids, if you get exacerbations there, you would want to give steroid cards too. The final one with this one is nebulizers as well. So patients, again, you would want patients with at home can use these products in a nebulizer type environment. You would get, you will want to talk to the patient about servicing the nebulizers on a regular basis. You would talk to them also about the spaces if necessary, and a rather how to describe it, rather sort of like a tender topic for quite a few pharmacists. Oxygen therapy. I know it's been taken away from you a long time ago, but again, being clinicians ourselves, we can't ignore the fact that a lot of these patients will probably receive some sort of oxygen therapy or potentially need some oxygen therapy, and just to make sure that they are receiving it on a regular basis. Again, with COPD, as you can probably see, a lot of these things are going to be just as applicable for asthma as they will be for COPD. Yes, I agree with you completely. I've got a very good comment by Hitesh here as well. What about the side effects on the mind map for anticholinergics such as tachycardia? I'll put them on as well. So with anticholinergics, I mean, you do tend to get some of the other side effects, tachycardia, dry mouth, the low vision, and those sorts of things as well, potentially as well, which I'll put in the final version of this as well. So that in a nutshell, I've just about hit time. I know it's been a whistle-stop tour of 4 very important areas, but hopefully this has given you some ideas as to some of the things that you could discuss with patients on this area. What I'm going to be doing next month even, is go over 4 more topics. It will probably be gastrointestinal, it'll probably be something like the high-risk drugs and a few others. To give you some more tips on this, and the idea is I want to create a library of mind maps so that you can actually leave in your consultation room and refer to it if necessary when you're talking to your patients on this as well. So I hope that's been useful for you. I'm going to open up the mics now, so if there's anybody who wants to talk to me, feel free to do so. Now is your time. Anyone talk to me? No. Thanks very much. Sorry, no mic. Okay. All right. Fine. I don't think anybody wants to talk to me today, so I do appreciate your time. I know it's quite late today, and I do appreciate all the time that you've taken today to come and discuss this with me. Same time next month as well. We'll be going over again the 4 main topics, another 4 topics on the MUR, unless any of you have got any more burning issues. A couple of things, these things will be online in a week or a week, so it'll probably be next week. If you want these earlier, I'm more than happy to email them out to you tomorrow. So if you want them earlier, let me just give you my contact details. I'll just put it up here. My email address is different at plusltd.co.uk. My telephone number there is 020-8863-3335. If you want anything, give me a ring. And that's it. I'm going to close now, so I'll speak to you next month then. Thank you to everybody here again. All the best and have a good evening.